I'd like to take this opportunity to welcome everybody here to the Aortic and Aortic Valve Symposium, which is our second meeting now for the Structural Heart Disease Australia program. I'm Greg Scalia, and on behalf of Sharon Kay and all the rest of the team, welcome to this collaborative teaching undertaking which we have instituted with the view to disseminating the knowledge base about structural and surgical intervention on the big valves, big vessels, and the other things which we're now doing in this space called structural cardiology. It's been a huge evolution and revolution in the last 5 years, where we've gone from imaging to see what surgery is needed to the surgical room, and then back to the treating physicians, and not really a lot of communication between all those disciplines. But now that this has become one discipline across many specialties: surgery, imaging, anaesthetics, interventional cardiology, perfusion, and so on. And all of us now need to know what everybody else does within this space. And we've had several conferences where we've had cross-discipline teaching and lectures, and I think all of us have learned a lot from listening to the knowledge base of each of the other specialties. I'd like to take this opportunity to congratulate Sharon on putting together this program, and I think we should give her a round of applause. For those of you who are not in the privilege of getting the 3 a.m. emails and text messages about the next idea for the next symposium, Sharon has an energy about her which gets things done. And to all those folks who are streaming, I think we have 11 sites streaming around the country, and also Southeast Asia in Bangkok, in Perth and so on. Welcome to all you folks. We will have questions from the floor here by the highly technical putting the hand up technology, and then from the other sites they'll be Twitter feeding in questions to the podium. We have 4 lectures in the first session this morning, and these are going to be about the structural elements of the aortic root, and then in the middle session we're going to talk about TAVI, and then in the afternoon we're going to talk about big vessel disease in the aorta. So with all of that, and I think, Sharon, if you're happy, we'll kick off. We're on time. Thank you all for coming in this morning, and I'm going to lead off and talk about imaging of the aortic valve. So what do we all hear about? Well, we hear about this journey where we've gone from the pathologist being the only person who got to see the aortic valve, to the surgeon who was the only person, to now all of us who have these incredible technologies where we get to visualise the aortic valve and root in the beating heart pressurised situation. This is a whole new world of being able to see this thing now in its fully pressurised circumstance. It's also a new world in that many of the things that we do now for the aortic valve are done just on this vision. They're not done with the eye, they're not done with the tweezers holding up, pulling on the valve and measuring length. This is all done now, or much of these things done are now minimally invasively or even percutaneously, so the imaging is everything. And so the aortic valve seems like a very simple passive structure, 3 leaflets and these sorts of line diagrams you would remember from teaching, and these sort of things you might show to a patient, but we all know that in fact the aortic root and valve is a very complex structure. So in the parasternal long axis view from the echo, you get this sort of a picture here, and you start to get the feeling of the aortic root extending down into the left ventricular outflow tract. You get the feeling of the ventricular septum merging with the anterior portion, and the aorticomitral curtain merging posteriorly. When you have a look at this aortic root like this, you can see that it's got 3 leaflets which are attached, so-called semi-lunar leaflets which are attached, and let's go through them. And the edges of the leaflets attach to the sinotubular junction. This is where the aortic root goes from bulging out back to tubular, and the leaflets attach around that circumference. There's a second line called the ventriculo-arterial junction. This is where the aorta goes from pink muscle to white artery. If you have a look, though, the actual base of the cusps of the 3 leaflets actually extend down below this junction, and so that each of the 3 leaflets extend and attach down further below this actual anatomical plane. Now this is pertinent because it's going to be relevant to what we see where we implant some of these percutaneous devices. So we can see that on 3D echo. You can see this ridge here of the actual annulus, and this diagram is very famous. I think it came originally out of the Cleveland Clinic, where it showed the 3 virtual, or 3 planes that we think about: the sinotubular junction plane, the arterial anatomic ventricle to aorta junction, and the actual thing which we call the annulus in echo in green there, which is basically the base of the hinges of the three leaflets. From this you can see that there is some of this white aorta which is still in the ventricle, or there has ventricularized pressure. And those three triangles there are still if you put a catheter right there, you'd have a V trace, a ventricular trace. And similarly, that there is some parts there of the bowl of the cusp which is attached to muscle or ventricle, but are aortified, if you like, or have aortic pressure if you put a catheter there. Will be pertinent to some of the procedures. CT scanning has changed the way we look at this completely, and using multiplanar reconstruction CT, you can get beautiful pictures of these planes. So this is a cut through the sinuses, and if you look at the the bottom left picture there, I've drawn that's the yellow plane. So that thing looks like an aortic valve, and you think, well, that's very nice, a symmetrical three-leaflet view. That's my aortic sinus plane. But in fact, most of the action actually is down at this green plane, and certainly where we try to centre our tabbies when we do those, we want to be on the green plane there. Have a little look on that left-hand picture there and see that the aortic annulus is anything but round and is anything but a thing. It's actually not a thing at all. What it is some muscular ventricular septum anteriorly, some membranous septum to the left on the screen there, the aorticomitral curtain at the bottom of the annulus there. So this thing is not a discrete, round, single fibrous structure like we might originally imagine. The sinuses of Valsalva are the bowl-like areas contained within the semilunar leaflets, and I think we're pretty comfortable with that anatomy. But let's have a think now about the anatomical relations of the leaflets and the sinuses of the aortic root. I commend to you this blue diagram. It'll be on the download in the teaching set, I'm sure. This came from Aubrey Almeida, and I've modified it heavily. But this blue diagram, I think, is everything. So have a look at that and just digest that a little bit, and let's start to have a look at the relationships of the aortic root. This is a view, a so-called surgeon's eye view. We're looking over the left-hand shoulder, down from the left, over the left shoulder, down onto the heart. And so those two pictures are laid out neatly together, and they should be aligned. And let's start to think through now the anatomy and the relations of these cusps of the aortic valve. Three cusps, of course, of the aortic valve: the right, left, and non. Let's do the right first. So the right coronary cusp is the most anterior structure there of the aortic root, obviously with the right coronary coming off it. And if you have a look there, the way it's lined up, the right coronary cusp is towards right atrium, and so you can see, if you can see right atrium in the picture, you're starting to look at right coronary cusp. It is also has relationships with the ventricular septum there, and in fact has its base in some folks actually on the membranous part of the ventricular septum. Looking from above there, it is associated, of course, anteriorly with the outflow of the right coronary artery, and is therefore rightwards and anterior. Looking again now with the 3D echo, you can see right coronary cusp associated with right ventricular outflow tract now as we're swinging across the front of the heart. And if we look now with 3D echo there's the right coronary cusp, and there's right ventricular outflow tract. Remember, when you get sinus of Valsalva aneurysms, they often impinge into the right ventricular outflow tract. And then as you swing more towards the left, then you've got pulmonary valve coming into view there, and that's pulmonary valve over there. So the right coronary cusp spans from RV inflow across to RV outflow, but basically associated with all the RV wraparound of the pulmonary outflow trunk. Now, the non-coronary cusp is the atrial septal cusp. So if you can see the atrial septum, then you've got the non-coronary cusp. And no matter where you're coming from, whether you've got 3D, 2D, looking from above, looking from below, if you can see the atrial septum, then you're in the non-coronary cusp. And so it's a more posterior structure there, associated with a little bit of tricuspid valve. Some of the views will have tricuspid valve in, and associated, obviously, as I said, with the atrial septum. It also is associated with the right trigone. You remember that the aorticomitral curtain spans from the right trigone, which I've drawn there, across the front of the mitral valve to the left trigone. So the non-coronary cusp is associated with the right trigone and the front and the right-hand side of the aorticomitral curtain. So there is the curtain there, and some people call it the intervalvular fibrosa, but we're going to just call it the curtain for the sake of this talk. Also, directly under that junction between the non-coronary and the right coronary cusp is the left bundle, and so this is pertinent to when we do some TAVI procedures, and the TAVIs extend down into there, we get conduction disease and heart block. It's immediately underneath there. Remember, the AV node is near the right trigone when they do mitral surgery. So sort of cartoonised version there, trying to give you the gist of the conduction system underneath the valve. Finally, the left coronary cusp is more posterior and obviously has the left coronary coming off it, but the important anatomical relation of the left coronary cusp is the left atrial appendage. Remember that if you see the left atrial appendage on any view, then you're far lateral. You're in the P1A1 part of the mitral valve, you're at the left trigone of the aortico-mitral curtain, so any time you see the left atrial appendage in the view, you're far to the left or lateral on the person, and it's the left coronary cusp coming off of the aortic root. So let's have a look at that. So left coronary cusp, that's the aortico-mitral curtain, the left trigone, and obviously the left atrial appendage. The left coronary artery comes off it, of course, and perhaps that left picture might be better to be slightly rotated anti-clockwise, and you've got LAD going forwards and circumflex going backwards. Now let's take this aortic valve now and unwrap it, because some of the relations of the aortic root are best seen in the unwrapped view. So let's have a look at this heart. We'll use this as our teaching model now for the next few slides. Left ventricle, ascending aorta, the anterior mitral leaflet there, the medial papillary muscle, the lateral papillary muscle, the aortico-mitral curtain there. And if you could put a pencil up underneath where I've drawn that red dot, that would be going up into left atrium. So that's the mitral orifice there with this thing laid flat. Muscular septum there. So let's have a look now. So this is a zoom in of the same picture, left ventricle, aorta. So the right coronary cusp, and you can see the right coronary coming off it, there towards the right and anteriorly on the person, the left coronary cusp over there, near the left atrial appendage, which is up here, and the aortico-mitral curtain. So the curtain is from the left and right, between the left and right coronary cusp like that there, non-coronary in the middle. These are these triangles I was showing you. This is where this is ventricularized. It's still in ventricle, so if you could put a catheter there, it would have a V trace, not an aortic trace. But it's going into it's onto the white part of the aorta where it's connected. The left trigone, the right trigone, this is the curtain here, and the membranous ventricular septum underneath the right coronary cusp. There is a portion of this part of the valve which has a communication between left ventricle and right atrium. So let's have a look at this anatomy. So this is the ventricular septum. This is the non-coronary cusp here, the right coronary cusp here. And there is a portion there, so because this is, if you read that note there, it says septal leaflet of the tricuspid valve. So this whole chamber, I beg your pardon, let's go back. This whole chamber over here is right atrium. This chamber here is ventricle. So this is ventricularized part of the left ventricular outflow tract, which if you punch through there in a Goberti kind of way, you'd have LV to RA fistula. That's how those things can occur. Now the 2D echo view is from below. So what I've got there is the surgeon's eye view from above. If we invert that and we look from the feet now, rotate that a little bit, this is what we all see in transthoracic 2D echo. So these are from the feet view, and so remember our anatomy here now, you can see the atrial septum, and so where you can see the atrial septum, by definition, is the non-coronary cusp. Where you can see right ventricular outflow tract, by definition, is the right coronary cusp, and where you can see left atrial appendage, which I think I've marked on here, so pulmonary valve, where you can see left atrial appendage is the left coronary cusp. So you're looking from below. All transthoracic echo looks from below. So left atrial appendage and therefore left coronary cusp. If you remember the landmarks and the associates, so you'll always get your cusps right. Atrial septum for non. Now here's a picture now where we've got simultaneously cut through parasternal long axis and then to get a short axis. And the idea was to emphasise the fact that the left ventricular outflow annulus, the actual aortic annulus, is not a thing. It's actually composed of some muscle, some membrane, and the curtain. And that, I think, is an important teaching point, because this is the pivot point where we want to get TAVIs to sit, and I'm sure the surgeons will teach us that it's also a point where they want to sew in their circumferential stitching for their aortic valves. So I've put now this CAT scan view next to this. This is now something we use as a standard, and in fact most TAVI sizing is done on CT scan, but they're basically the same imaging and designed to show the various components there of the aortic annulus. The right coronary artery is easily visualised in most people if you scan upwards a little bit, and right coronary artery coming up there obviously off the right coronary cusp. And you can see now left main coming off the left coronary cusp with the LAD going anteriorly and the circumflex hooking around the posterior annulus of the mitral valve. In our parasternal long axis view, you look like you've got a symmetrical cut through the aortic valve, but it can't obviously be symmetrical, otherwise you'd actually be cutting through the commissure between LCC and non-coronary cusp. So typically in a parasternal long axis, you've got right coronary cusp anteriorly and non-coronary cusp posteriorly, which actually means you've pivoted slightly towards the right side when you do what you think is a symmetrical parasternal long axis view. And you can tell this is true because this is the medial pap muscle. Remember that in a true long axis you should pick up no papillary muscles. Right coronary cusp, non-coronary cusp. Aortico-mitral curtain. Scanning more towards the medial, you bring in RV, and remember when we said we see RV and RA, then you know you've got right coronary cusp, bringing in the septum there, showing its attachment to the base of the right coronary cusp. So right and non. In the 5-chamber view, which is another way you can get access to aortic valve, this is a right coronary cusp, left coronary cusp view. So you've got some muscular septum, so you know when you've got a muscular septum in view there, muscular and ventricular, membranous septum and muscular septum sort of combined there, you know you've got right coronary cusp coming into view, and then in this view you've got the left, and you can tell that it's the left because you've got left coronary coming off there. Circumflex coming around the AV groove. Now in transesophageal we've got yet another approach at this because we're looking sort of from above but upside down inverted compared to the surgeon's eye view. So use your landmarks, the right coronary cusp next to the pulmonary valve and tricuspid valve, the non-coronary cusp adjacent to the atrial septum. And so looking at that, and I've just rotated this a little bit, the transesophageal short axis basal view there is from above but upside down compared to the surgeon's eye 3D view that we're starting to get used to looking at all the time. Non, left and right coronary cusps. Now just before we cater off the anatomy, I just wanted to talk a little bit about malformations of the aortic valve. There are 2 fundamental sorts of bicuspid aortic valves. And the first sort is where you have basically 3 leaflets, but you have fusion of 2 leaflets, and the commonest being the fused left and right, but we can also see fused right and non, and more rarely non and left. And then the alternate type is the so-called true bicuspid aortic valves, where in fact there are 2 sinuses of Valsalva rather than 3, and 2 relatively symmetrical leaflets, either opening in an AP direction or medial and lateral. I'm sorry, I just don't have a running one of those. So that's the anatomy of the aortic valve and aortic root. Let's talk about what we want to measure. We want to measure 2 things. We want to measure dimensions, and we want to measure gradient functional data. So let's go with dimensions. So we can measure a whole bunch of numerics of the aortic root, the sinotubular junction, the sinuses, and the AV ventricular aortic junction, but we call this the annulus basically. And this, remembering having back to our green and yellow planes that we saw before, this would be equivalent to the green plane. So measuring these things, we can do this on transesophageal or we can do it on transthoracic. We get a whole bunch of these dimensions, diameters and heights. We also now, for aortic valve repair, like to measure the effective height of the leaflets, which is fairly easily measured in transthoracic echo and TOE, and also the coaptation distance, pertinent to repairs of aortic valves which are done particularly in bicuspids. Coaptation length and the effective height of the leaflets, and there are normal range data available in your slides. We talk about the fact that we like to measure the annulus, the ASE guidelines, and there's going to be more about the guidelines in a minute, in the long axis view and the black-white interface, and you can read about that there. But fundamentally, the biggest view that you can get, and working hard to get down onto the hinge point, remembering that you often will see chunks of calcium at the hinge point, which tend to make us underestimate. Be careful because you're not measuring a circle, and if you go off axis a little bit, then particularly in what looks like a symmetrical view, which is that left dotted line there, you're actually not necessarily measuring the actual annulus directly, which will bring us to the CT scan data in a minute. Now, echo has become the gold standard for the functional assessment of aortic valves, with transthoracic a continuous wave Doppler, now 4V squared, being the standard. And in fact, if the catheter doesn't agree with 4V squared, you say there must be something wrong with the catheter, which is very interesting because it's the only place where echo has truly supplanted the cath lab as being the gold standard. For example, in the right heart and tricuspid and so on, it's the other way around. If they don't agree, you say there must be something wrong with the echo. Remember that with the echo, we measure the peak instantaneous gradient, so that 4V squared is actually the biggest 4V squared that you see in the ejection systolic profile. So we actually measure the distance between there and there, the peak instantaneous, as opposed to the cath lab people who measure the distance between P1 and P2 in blue there, which is called the so-called peak-to-peak gradient. And as life would have it, their peak-to-peak gradient is actually very similar to what we would call our mean gradient, which is the area between the two, or the shaded green part. So their peak-to-peak should correlate very well with our mean gradient, which is basically the area under the curve, as put there in green as 43 millimetres of mercury. Now, all of you will know this data, so I'll move quickly through it, but basically normal humans have a velocity through their aortic valve of about 1 metre per second. When you go from above 1 metre per second up to about 2.5 metres a second, you'd call that maybe that in the normal range. Above 2.5, you'd call it maybe mild stenosis, but above 4 metres per second, you'd call it severe. Now, it used to be 5 metres a second when we all trained, but now it's 4 metres a second. The American guidelines have talked down what constitutes severe aortic stenosis. I think this would be in keeping with a more aggressive American surgical strategy, but in fact what it does allow you to do is to call stenosis in the 4 to 5 metre per second range severe, so that you can do surgery if that's what needs to be done clinically, with the condition still being called severe. To calculate the valve area, you measure the peak velocity by continuous wave, the subvalvular velocity by LVOT, and using this formula here in the continuity equation, basically if the valve area if the velocity going through the valve is 5 times faster than the velocity below the valve, it must be 1/5 of the cross-sectional area of the left ventricular outflow tract, hence the continuity equation. We very, very rarely planimeter these valves because we almost always get it wrong when we planimeter them, and so I put it to you that 4V squared of the continuous wave and the continuity valve area by far and away are the gold standard. Lastly, I want to talk about aortic regurgitation, and just like in mitral regurgitation with the Carpentier classification, there is a classification of aortic regurgitation of almost exactly the same concept. So, type 1 dysfunction of aortic valves to make them leak are fundamentally those ones where the leaflets are normal, but there's something wrong with the aorta. Just like the same thing with mitrals, type 1 is where you've got dilated annulus or cardiomyopathy. Similarly in the aortic folks, type 1 dysfunction is where you've got ascending aortic aneurysm or effacement of the sinotubular junction, or some other thing that rolls the leaflets outwards to make a relatively central jet. Type 2 is where you've got leaflet prolapse, and you might say, well, who sees aortic valve prolapse? But you do, particularly in bicuspid people or people who've had infection. And type 3 is restricted motion, typical of rheumatic heart disease. So here's an example of type 1, where you've got an ascending aortic dilatation and effacement of the sinotubular junction, and as you expect, a central leak. Here's an example of type 2 with aortic valve prolapse, probably infected, or perhaps traumatic, but one leaflet obviously prolapsing below the other, and clearly eccentric jet. And finally type 3, where you've got rolled edges and the leaflet just doesn't coapt in the centre, and they usually will have, I beg your pardon, that's type 2, I'm sorry, and type 3, just move forward. Let's move forward. And type 3, where you've got rolled edges and the leaflets just don't coapt, typically of a rheumatic nature, and you'll have a central leak. Lastly, and we're going to talk in the last section, we're going to talk about aortic, the great vessel. The aorta is not well imaged in its entirety by echo, but CAT scan and aortography obviously are the standards for this. But within our world of echo, we see the ascending aorta. Note the ascending aorta as it wraps around the right around the pulmonary trunk, and we obviously are able to make dimensions up to the mid-ascending aorta. We're not bad at imaging the arch in echo, and we can look at the beginning of the descending. But fundamentally, CT aortography, MRI aortography have supplanted us for the great vessel part of the aorta, and I'm sure we'll have lectures about that later on today. And so these sorts of beautiful 3D pictures of the aorta have been a revolution. Similarly now, fusion imaging is allowing these 3D images to be then superimposed upon beating heart angiography, and so for some of the procedures that we're about to do and we'll talk about today, TAVI and so on, we have CAT scan data which is then superimposable in real time live on top of beating heart pictures to allow us to exactly place these devices accurately based on landmarks and data that we've got the day before from scanning. So thanks for listening to that. That's a sort of a setup for the day. We're going to ask now for Dr. Mather to come and talk to us about understanding and putting the guidelines into place.